Hi, and welcome to Green Space Behaviors tutorial on conducting risk assessment, risk mitigation as part of delegation within your supervision practices. So what we'll do is I'll just go over a brief primer. If you want more information, I'll definitely have resources linked and some additional YouTube videos to help enhance your own supervision practices. But for purposes of today, let's go over how you can use this graphic to guide you in making better clinical decisions when you need to make a delegation evaluation. So the task list items that are driven by our governing national entity, the Behavior Analyst Certification Board, basically encompass a list of technical skills that set forth minimum knowledge, skills, and abilities that are part of what we deliver to consumers in under behavior analytics services to a single consumer or different entity types. And the main activity where we are delivering is, in fact, the task list skills to the consumer. So within the context of making delegation decision, this is really important for everyone to sort of align to, is that the person receiving the service should expect that they're getting services delivered by a competent person, or that the person who's delivering the service is under direct, close supervision if the person delivering it, so think of a student teacher or medical intern, that the person that is actually delivering that service, if they're not having met those performance criterion yet, that there is someone literally there watching them, like the teachers in the classroom with the student teacher, the doctors literally with the intern in the room, so that there's direct, close clinical supervision at all times, and that we're not leaving the patient or the recipient of the service alone with someone who has not demonstrated competency. That is important to conceptualize as we're going through this graphic and considering that as a foundational aspect of delegation and what the consumer should be expecting when someone is providing a service who has not demonstrated full competency yet. For whatever reasons, it could be part of a natural staggered teaching process, but it's important to recognize that as sort of a fundamental concept that occurs across closely related partner fields. Now, for using this graphic, what you'll want to do is first start with, what is the task list item I need to consider delegating that may need to be delegated ahead of full knowledge or performance competency being demonstrated by an RBT, trainee, or supervisee. So you need to have clarity on what the task item is, making sure you're aware. And if it's performance-based, or it could be performance and knowledge-based, it's important you have distinctions and clarity. You need to also have clarity on what the criterion should be in order for them to have already demonstrated or be towards going to demonstrated competency. So those things need to be very clear as you're going to use this matrix. And you kind of also need to know where that person lies within that continuum of demonstrating or working towards demonstrating that competence. So they're really close, they're one more demonstration away, and then they have met the criterion. So you need to also have that information available when you're looking at the task list item against who you're going to be delegating to in the absence of a full criterion component being met. And then you also need to have very good case familiarity before you make a delegation involving an individual case with a client, stakeholder, other type of consumer. When we look at this particular graphic, what we're looking at is the top is called the scale of severity. And what that means is when you're evaluating that particular task list item and then overlaying, if I'm not on site, literally supervising this person's performance of this task list item, what is potentially going to happen to this particular consumer? Okay, and I'm going to show you a graphic in a minute. Once you determine what that potential risk for that particular patient could be with that particular task list item, then you need to ask yourself, is this outcome generally unacceptable, tolerable, or acceptable in practice? Okay, just in general, like, broadly speaking. And then you overlay the scale of likelihood for your particular patient that you're delegating. Is this not likely to happen as an outcome? Is this possible, like 50-50, or is this more than 50% probable that this will happen to my particular patient, client, or whoever my consumer is? And then that gives you and provides you with a categorical rating of low, medium, or high. You cross those two variables and you find where they align on this graphic. So let's just go through some cases to illustrate this as a skill. Here's the note I made about risk. If you're going to incorporate risk assessment matrix into your practice, it's important for the purposes of making routinely standardized decisions that you have what's called behaviorally anchored rating scales that you link and make those decisions about what possibly could happen when I make a delegation and the supervisee or trainee or whoever it is under my supervision and care is not fully demonstrated that criterion for that taskless item, what could potentially happen for this taskless item with this particular consumer? So you have to know those things, and then you need to have like a scale of where that may fall. And these are just some ideas of what that could look like, because we know we're dealing with taskless items that are technical skills. So examples would be, you would ask yourself these guiding questions. If I delegate this taskless item ahead of this particular supervisor or trainee, having met full demonstration and criterion, whatever that is for that item, would there be immediate harm to others or self? Would there be predictable intense emotional side effects? Would there be severe disruption or complete stop in services if it's like OBM, like an entity? And then you move backwards, and you can see here where you just guide yourself to ask those questions. You need to know, if I delegate this taskless item ahead of this person having fully documented full performance demonstration, meeting competency to where I don't have to literally be in the room supervising, going back to that medical model or other models where you have the intern with the doctor, you have the student and the student teacher together. So if you're not literally with that person, and in your absence of direct clinical supervision, what would potentially happen if you are not literally supervising a direct clinical skill that needs to occur with a patient in person? Okay. So let's look at a real example. Okay, so let's take taskless item, which is just collecting rate, number of times a patient uses a cuss word in the school setting. So for this particular guiding question, I would say, if I delegate this to my RBT ahead of her completing the entire performance demonstration for data collection on rate across multiple exemplars, she hasn't fully met that yet, but she's met certain parts of it, is that in this particular client, it's a student in a public school system, we've identified that that would potentially result in some delays in how the BCBA and the school psychologists are making tweaks in the token economy, but the child will not be restricted from the current environment and would not be expelled or suspended. So we've determined that the potential outcome could be there may be some delays and tweaks for shaping and pushing up like thresholds for whatever the procedures are for tolerating, additional time for non-preferred. And so we've determined for this that potential outcome would be tolerable and potentially even acceptable, because there is going to be a margin of error in just in general when you're collecting data. And that's why there's an 80% threshold for inter-observer agreement, IOA. So you could say it could float between acceptable, tolerable, and for there to be an outcome that there could be some slight delays and clinical adjustments that would help or just more optimize the actual patient's current plan of care for his behavior intervention plan. However, we are identifying that we'll say here it'll be an acceptable outcome if there's a small delay for that particular patient profile. And is it likely, possible, or probable that that could happen, in fact? So we're saying that could happen, but for this particular case, we're going to say it's possible, meaning 50-50, that the data, if it's not collected at 100% accuracy, it could potentially cause the BCBA to not, let's say, push a shaping target, a successive approximation, like right when she has so many days at criterion at 100%, but let's say the RBT is not collecting the swear words at complete 100% accuracy. So we'll just say that in this case, it's possible that may impact some of the changes. However, on this particular threshold, we see that it rates as low. So this is a low risk item. If you need to delegate it, you can delegate it more comfortably, knowing that you've got your documentation and your RBT is working towards demonstrating complete mastery of this across multiple exemplars, but that you could delegate this with low risk to the actual consumer in this particular case. Let's move on to another example. Errorless learning with a caregiver goal And so the potential you consider, if I delegate this errorless learning procedure to the parent without, and meaning I'm not on site supervising this particular errorless learning procedure for a self-help adaptive skill, what potentially could happen, and is that acceptable, tolerable, or generally unacceptable? And so for this particular profile, we identified that it would just mean that there may be a slower acquisition rate, because these trials would be very distributed trials that would occur low frequency anyways, and they are not part of the other skill acquisition treatment plans. Is there self-selected goals that the parents working on, and so that the trial count would be lower, so that while we're working towards helping that parent demonstrate full competency, the parent would like to try the procedure ahead of completing like a full protocol with you. That is it acceptable, tolerable, or generally unacceptable if there's like a slower acquisition rate. Okay, and then we would say, is that not likely, possible, or probable? So I would have to know the patient's profile, and I would, in this case, say it's tolerable that we would let the allow, like meaning like the slight delay in acquisition of the self-help adaptive skill, but it's not likely to occur for this particular patient based off of this patient's profile. So we would say this is a medium level of risk in this particular case, and that what with the decision we would make is we would confer with the parent, document what we would want to do, and just be really clear about the decision to say, yeah, go ahead and start doing this, but recognize you haven't demonstrated, let's say, 6 or 7 consecutive demonstrations with me before I'm releasing you to start working on this hand washing or toothbrushing skill. And so as long as that's really clear and you have that conversation and you're documenting that, and then you're clear about how many more interventions or coaching sessions you need to do, but that's sort of kind of helping you make good clinical decisions and documenting everything you're doing in relation to the task list item, the level of potential risk to that particular case, and what exactly could happen if the delegation is made ahead of that performance competency completed. Let's do one more. Implementing a crisis plan with physical restraint. So in this case, it's known that there is interfering behavior occurring if there's already a crisis plan. And if someone's requiring physical restraint, it means there's probably some potential for adverse harm to self or others. So we would say that that would be generally unacceptable to delegate this task list item, knowing that this is already has pre-existing context for someone is already potentially going to harm self or others. And so it's generally going to be unacceptable to delegate this ahead of a clear competency measure being met, in order for the supervisor to not be on site directly when this procedure needs to be done. Okay, so we would say that's generally unacceptable. Now, how likely it is to occur for this particular patient, meaning this particular patient, is it likely that that potential outcome could happen? Not likely, possible, or probable in the use of an actual restraint where the person they'll need that restraint and or that they possibly could harm themselves or even the potential supervisee or RBT due to inappropriate technique. And we said it's possible, it's 50-50 for this particular patient due to the dynamic variability within the child's or the student's profile right now, that it's possible that something actually could happen because we have data right now on recent behavior to lead us to believe like it is possible someone could get hurt, that actually could happen if we make that delegation decision without proper techniques being used and demonstrated and documented clearly. So high would mean we would need to continue clear on-site supervision and not delegate off any of this particular component until the performance criterion and competency has been fully demonstrated by the RBT, supervisee, or any trainee. Okay, that is it for our overview of how to use this risk assessment matrix. Remember, this is a guide to help you consider additional components involving risks before you make a full delegation decision. It helps you critically think through these components and recognize that with each task list item, there are going to be some task list items that will present a higher or medium or low level of risk. And that also puts the responsibility on you to supervise, consider your necessity to be on site provide direct clinical supervision more frequently if a taskless item has not been mastered fully. So these things help you just consider what your behavior needs to look like as you're supervising ahead of making a delegation. And you can make delegation decisions with additional conditions, but it needs to be clearly documented, and you need to have a clear performance plan on what you're doing in order to help that particular RBT, trainee, supervisee, whoever is under your care for supervision, meet that performance criterion in an ethical and responsible way to the consumer involved. If you have any questions, let me know, and we have more resources at greenspacebehavior.com, YouTube. Thank you.